Bismillah ar-Rahman ar-Rahim. After the sprint, after the step, we will go to the guideline. I have the privilege and the honor to introduce Professor Dr. Ahmed Shawky, Professor of Cardiology, Ain Shams Faculty of Medicine, who will talk about recent European Society of Cardiology guideline in management of hypertension.
Thank you for the lovely introduction, my dear colleague and friends. It's a pleasure to be here. سمعنا كلام كتير النهارده. Let's try and discuss what are the guidelines and what is going on. Because we have a lot of ideas that the guidelines are different when actually they're very similar. This is my disclosure for this session. And what is the first question when I treat a hypertensive patient? What is the main things that we're looking for? Is it control of blood pressure? Definitely. Is reduction of target organ damage, and all blood pressure medications reduce blood pressure, but not all of them are protective as each other. Controlling the risk profile of the patient and avoiding side effects. And we've seen sometimes with intensive use of diuretics, we get hyperglycemia, we get hypertriglyceridemia, and also renal affection as seen in SPRINT. Or all of the above? Definitely, we agree that all of the above. So this was highlighted yesterday that overall cardiovascular disease kills around 17 million people, and blood pressure, regardless of the socioeconomic standards, is the mainstay for all patients as a risk factor. And in Egypt, it was for the 100 million, 100 million صحة, we showed that there are 20% of adult Egyptians having hypertension, and this contributes to 30% of non-communicable diseases, thus cardiovascular death. Well, like, the bad news is still, if you look at the WHO data from Egypt, and this is our data, not the WHO's, that the mortality from hypertension, ischemic heart disease, and stroke is quite high. Why? Probably because we are not controlling that well, probably because we're not using the best of medications. Could be a lot of factors, and there are other confounding factors. So what are the control rates? This is important. We need to have a blood pressure reduction. If you look at the United States, and this is talking about the older guidelines, we're talking about the 140, not the 138 and the 128 as you've seen today. The affection of blood pressure and the control is quite poor, even in Europe, especially this is Eastern Europe, which is a little bit like us. And the first data actually for us was presented by Professor Mohsen Ibrahim late in the 90s, and still, this is not, okay, this is working now. And still, we're not there when we're talking about the older targets of blood pressure control. So why is this? This is the first question that comes to mind. Why are we not controlling the blood pressure? One, this blood pressure increase is an asymptomatic disease. And if it's an asymptomatic disease, the patients usually do not take the right side, do not take the right medication at the right time. They say, okay, I feel well, let's skip a dose. And this is very common in asymptomatic disease. Thus, compliance goes down. And the compliance is even worse when we're talking about asymptomatic diseases as compared to symptomatic diseases. So what do we have to do? First of all, we should attain the target blood pressure. I remember very well, Dr. Ghada, we were doing this debate, I think maybe 4 years ago. And we're talking about the newest of guidelines. It was the American guidelines in 2017. And there was this debate that you won, of course. I was the intensive blood pressure reduction, and it was according to the SPRINT trial. Professor Karim Saeed highlighted it very elegantly and discussed it in detail. And in 2017, in November, actually the American guidelines were published going to 130/80, and there was a big row around the world. This is too low, this is not good. Let's wait for the European guidelines in 2018 in August. And actually they said the same thing. Unless the patient has a CKD, the patient is extremely old or above the age of 65, it's preferable to go to below 130/80. And 80 is the guidelines as per European. It was not so different from the subsequent Canadian guidelines, even going for very high-risk patients to below 120. And we've seen today, the KDIGO guidelines go to below 120. The International Society of Hypertension published the guidelines in 2020. This is probably the newest ones. And again, optimally go to below 130/80, especially if the patient is below 65. So actually, the targets are the same. The guidelines are nearly the same. So when talking about targets, we should go lower, and this is important. Comes the big question. We've seen today monotherapy, dual therapy, quadruple therapy, triple therapy, what to do. This is important, and if we look at the ESC 2018 guidelines, they suggest, they prefer, Dr. Omar, I quote him always saying this is not, part of the religion. This is a question that we can ask, do with or without. A combination therapy from the start, a single pill therapy. Is it a RAS blockade, a CCB, or a thiazide or thiazide-like diuretic? This is the initial therapy. Why? To improve control, to improve protection, to improve outcomes for our patients. If you look at the ACC, AHA guidelines, actually that were presented maybe 8 months before the European guidelines, also they said if we have the blood pressure still a bit higher, a combination pill is a class 2A in most patients. If you look at the Canadian guidelines, they suggest any medication, but if you look at the box downstairs, of course, go for RAS, CCBs, diuretics in a single pill is the preferred choice for better control. If you look at the ISH, the International Society of Hypertension guidelines, it also says go with a combination therapy from the start. And here it's a little bit different. If you look at what it says A and C. What is A? A is a RAS blockade, C is a CCB. Why is that? Probably because the CCB has higher protective data for the cardiovascular continuum than the thiazide or thiazide-like diuretics. We said from the start, all medications reduce blood pressure, not all medications confer the same protection. So what is the rationale? Definitely better control. 2 drugs are better than 1. We've seen this consistently. 2, we've got different mechanisms of action. 3, we've got different mechanisms of protection. This is important. And it decreases blood pressure variability, especially in those who are prone to strokes. But if your single pill combination is not working, is not reaching the target, this is a very important question, which is a little bit subtle in the guidelines. What do we do? Do we go to triple therapy or do we up titrate the doses? And this is a question really the guidelines did not allude to very nicely. But actually the only guideline that stated that was the International Society of Hypertension, which is by chance the latest published one. And it says, go to the highest concentration possible. If you look at step 1, start with a combination therapy, preferably A and C, which is a RAS blockade and a calcium antagonist. Of course, we know preferably amlodipine in most cases. And step 2, increase the dose. Why is increasing the dose important? It's not just reduction of blood pressure, it's protection. We've seen this consistently in heart failure, in chronic kidney disease. Increasing the dose of medications, especially when we're talking about RAS blockade, improves mortality, morbidity, and comorbid conditions. And then after, using the highest possible doses, then triple therapy is the best. And this is the latest guidelines coming from the ISH. So of course, this is a promotional lecture. So let's just take a look about the medication provided here, valsartan, amlodipine. Why valsartan and amlodipine? This is a question. First of all, we know that ARBs are probably the least discontinued medications. The side effects are just like placebos. This is very important to take into consideration. We want to give to a symptomatic patient a medication the patient will not complain of. What's the use of giving a patient who is asymptomatic a medication that will cause side effects? And this is very common with diuretics and beta blockers. Of course, the selectivity on the AT1 receptor, this is, of course, pharmacodynamics. For my perspective, I don't really believe in this. I believe in data. And when we talk about data, there is no more comprehensive data than valsartan. It has been used more consistently than any other ARB in randomized trials. It reduces blood pressure, definitely. And it does this more than placebo. And when we have peripheral edema that is associated with the use of amlodipine or felodipine, this decreases when we have venous dilatation by a RAS blockade like valsartan. Also, the combination is proved better than a monotherapy with valsartan or amlodipine, more powerful. This is the first step, reduction of blood pressure that we're looking to. Also, it provides incremental blood pressure reduction. That is to say, if the patient has mild hypertension, the reduction will be a little bit less. If he has severe or she has severe hypertension, the blood pressure reduction can achieve up to 40 and thus go into the target blood pressure grounds. And also the target organ damage. If we see the regression of left ventricular hypertrophy, we've seen the data with the RAS blockade and the calcium antagonist. Definitely the reduction here is significant. Not only that, if we look at real world safety and efficacy, we've seen this a significant reduction in grade 3 blood pressure, significant up to 55 millimeters mercury, and this is very important in patients with hypertension. Not only that, it reduces one of the important problems that is caused by beta blockers. Beta blockers are great medications. They will never be stopped to be written by cardiologists, but they do not reduce the central blood pressure. They do not reduce significantly stroke rates. This is different from the vasodilators like amlodipine and valsartan. And reduction of the central blood pressure was an important integral part in the ASCO trial, ruling out beta blockers as a very important first line in that. And if you can see, definitely calcium antagonists, ARBs, they do very well in reduction of the central blood pressure. If you look at also kidney outcomes, definitely the kidney outcomes are better with using of the ARBs and ACE inhibitors than other medications. But not only that, if you look at the data for valsartan, definitely, it has the widest range. And we've seen yesterday with a very fruitful discussion and presentation by Professor Gamila, it is the only medication that can be given in children. It is the only ARB with an indication in children, but definitely it has protection all over the cardiovascular outcomes. This is quite important. Amlodipine has the same. Diuretics are very good medications, but they do not have that high amount of protection data. They're very good. They're very potent. They prolong the action of other medications when combined to, but they don't have that protection data. So this is why valsartan has probably the highest number or the most number of indications per molecule in the ARB group to be given. And it also is being shown a side effect, which is an important side effect that we've seen with amlodipine. The incidence of lower limb edema is lower when combined with amlodipine versus other comparators. And this is why the guidelines state that calcium antagonist and ACE or ARBs are recommended. This is the European guidelines. These patients with diabetes are very important to manage. Remember, thiazide diuretics, very good medications. They might induce a little bit of hyperglycemia, hypertriglyceridemia, and hyperuricemia. And so is reduction with albuminuria. Again, there is this recommendation for RAS blockade and CCBs. So to stick to time, as we've seen, hypertension, the leading cause of death as a risk factor. 10 million deaths yearly are linked to hypertension directly. And controlling of the blood pressure is quite difficult. With the older cutoff points, it was difficult. With the newer ones, I don't know what the data will look like. But not only all antihypertensives reduce blood pressure, but not all of them have cardiovascular protection. So when using medications to produce blood pressure reduction, don't forget that the risk factors and the cardiovascular protection is an integral part of managing our patients. And thank you so much.
شكرا جدا دكتور احمد على المحاضره الرائعه. احنا في اي كويشن من الفلور؟ دكتور عمر.
شكرا يا احمد على المحاضره المتميزه كالعاده. انا بقول هو فكره الكومباينيشن ثيرابي ابتدت لما لقوا ان البروجنوزز of treating a hypertensive patient is not depending only on the lowering of the blood pressure, but the rapidity of achieving this level of blood pressure level. When we are selecting a combination therapy, usually you are depending on 3 factors: the age of the patient, the level of the blood pressure, and the degree of the risk of the patient. احنا بنسمبليفاي المطر قوي في علاج العيانين بتوعنا، يعني لما يكون ضغطك كذا خد كذا خد كومباينيشن، وبنغفل حاجه في منتهى الاهميه وهي في اليوروبيان جايد لاينز. When we are deciding to treat our patient, in our mind should be the level and the risk. The European guidelines are telling that when the patient is high normal blood pressure, but he is very high risky, high normal, not stage 1, you start giving medication. When the patient is stage 1, but he is a very low risk, you start to give lifestyle modification. فالsimplifications of matter وهي في اغلب اذهان الدكاتره ان احنا we are looking just for the blood pressure. And it's not true. لان لازم يكون في اختيار depending على الفاكتورز و depending على our يعني thinking of the future of that endpoints. فرأيك؟
طبعا very well noted Professor Omar. Definitely زي ما قلنا, it's not just the numbers, it's also reducing the cardiovascular risk. And combination therapy, not all combinations, not all of them will reduce blood pressure, but not all of them will confer cardiovascular protection. Well noted, sir.
I just would like to emphasize what Dr. Omar said now, the importance of the lifestyle modification. As we know, and we have seen this morning from Dr. Mohsen's lecture, that the reduction of weight, exercise, reduction of salt, and so on and so forth have a substantial reduction in the blood pressure, even more than the drugs. يعني Dr. Ahmed, we are at the physician who don't give time to explain that to the patient, and this is a problem الحقيقه لان احنا طبعا الناس كلها مشغوله ومستعجله وحاجات من هذا القبيل. لكن it is actually a very important aspect in the management of hypertension and cardiovascular diseases at large.
شكرا دكتور احمد. For the sake of the time, we will go to the end of this session.